Welcome and thank you for joining us for the SPH Analytics webinar, Improving CAHPS with Drill Down and Simulation Surveys. We recognize that some of our valued clients have joined us on the call today. We'd like to recognize them and appreciate their business, and we are glad you were all able to join us. We will have a question and answer session following our presentation today. Please type any questions you have for our presenters into the Q&A tab of the WebEx portal at any point during the presentation. We will also be recording today's webinar, and we will make the recording as well as the slide deck available to our attendees following the webinar. Now I'd like to introduce our host for today's session, Alyssa Simpson. Alyssa is a Senior Sales Executive with SPH Analytics. Welcome, Alyssa.
Thank you, Terry. During today's webinar, we are going to review some examples of how CAHPS drill down and simulation surveys can be used to help drive quality improvement. We are so excited to have guest speakers from Alignment Healthcare and Select Health to share their experience and insight into how they have utilized drill down or simulation survey tools to improve experience and satisfaction of their members. We will also review some best practices and survey updates from our Senior Product Manager, Esther Turner. SPH Analytics offers a comprehensive line of health plan solutions, including complete management of regulatory surveys and elective or non-mandated surveys. This includes pre-survey guidance and consultation, on-site administration of the entire survey process, and comprehensive reporting and analytics. We also provide member engagement and outreach through our on-site healthcare call center, and we've been providing healthcare call center solutions for more than 2 decades with on-site, highly trained and professional phone agents. Our consulting services are also available to help you put all the pieces together. Our consulting services provide an objective review of your survey results and offer guidance and recommendations to help you improve performance, enhance member satisfaction, and increase scores and star ratings. SPH Analytics has a sophisticated system and resources that support our commitment to perform at the highest level, including highly developed quality controls and checks, superior standard protocols. We go above the standard requirements with highly involved systems, quality checks, and dedicated resources. We use advanced analytics to help guide targeted and measurable improvement. We are also continually providing tools and resources to help our clients improve scores, performance, and the quality of care. The SPH Analytics drill down survey tools were developed to obtain member feedback beyond the standard CAHPS surveys and to explore and identify key factors in influencing member satisfaction. The survey allows plans an opportunity to drill down on key components by using core CAHPS survey questions and adding in supplemental questions to explore the reasons behind their member responses. The surveys provide an opportunity to add open-ended questions as well as several write-in response choices. So now let's look at our simulation surveys. Health plans opt to conduct simulation surveys for several different reasons. They administer the survey during the off-season or before the regulatory timelines to track results and make needed improvements prior to the next regulatory survey administration and submission timeframe. Plans might also conduct a simulation study as a baseline survey if they have not yet been required to conduct an NCQA or CMS survey but anticipate the requirement in the near future. SPHA's simulation surveys include comprehensive reporting for timely action-oriented improvement initiatives. It also provides performance improvement resources and recommendations. SPH Analytics is an NCQA-certified CAHPS vendor and a CMS-approved Medicare CAHPS survey vendor, and we've been conducting these surveys since they were both initiated. I'd like to now introduce our first guest, Christina Lateral. Christina is Vice President of Quality Improvement and Risk Adjustment with Alignment Healthcare. Christina has worked in the healthcare industry for many years, fusing with different administrative functions of healthcare, allowing herself to make a modest but forceful impact. She has demonstrated much success in developing and implementing clinical quality metrics, achieving cost reductions, and improving satisfaction with both internal and external customers. Her background and expertise is vast and includes experience in many areas from claims, configuration, payment policy, electronic data interchange management, call center oversight, CMS Medicare Star Measure Program development, Medicare Risk Adjustment Program management, and oversight to NCQ accreditation programs. Thank you, Christina, for being here, and I will now hand it over to you.
Thanks, Alyssa. I'm happy to be here and welcome everybody. Today we're going to talk a little bit about how Alignment identified some need within the CAHPS survey for the Medicare population and how we implemented change related to survey results. Alignment Healthcare is a healthcare company that provides health insurance plans and services that are designed to help coordinate care for our senior population. We're a fairly new organization, and we have about 40,000 members across 3 independent states. Our business model differs depending on the partnership we have. Within California, we are strictly a pure-play health plan, and then in the 2 other states, Florida and North Carolina, we are functioning as a delegated entity. Next slide, please. So what Alignment did was identify a need based off of prior year's CAHPS survey results to implement what we called a provider ecosystem. And part of that provider ecosystem was to understand how provider offices are operating that affect our members' perceptions. So in June, we launched with SPH the proxy or drill down survey to more clearly understand how our providers or how our members were identifying their provider experience. Next slide, please. So what we did is we developed the drill down survey according to prior year's results. We implemented 3 different waves in 2016. There were about 2,000 surveys that went out per wave. We deployed in July, September, and October. And we made sure that those members that received the survey actually had a visit with their provider. We also deduped from the 2016 official CAHPS survey and also from each of those independent waves that went out. So we made sure we were hitting unique members. What we did then with those survey results is we implemented a 2-step methodology where we correlated each of the drill down questions to a specific CAHPS question that was used on the actual survey, and then we calculated a composite score based on the correlated questions or the inverse depending on what the question was. In Q4, we took those results and we started what we called a provider roadshow. We leveraged the network team to schedule meetings within our provider community, and we indicated their results compared to the Alignment Healthcare results overall, and in comparison to each of their competitors within the market as well. So these 2 slides, this one and the next one, you can shift to the next one, just show what we did and how we went out and communicated to each of those independent physician groups. We also showed them a comparison to CMS star ratings and percentages year over year to help them more clearly understand how what they were doing was affecting the overall Medicare Star program. Next slide, please. What we did when we went out and talked with each of these groups and presented the information to them or the results to them during the roadshow is we developed also tactical action plans. So we created work plans associated with each of the specific measures, explaining to them what the measure questions were, what year-over-year results were, and where they were currently at. We came with recommendations for them, but oftentimes we found that they had processes in place that they were thinking of implementing themselves. So we really worked with them, coordinated and partnered with them to ensure that they were processing or developing processes operationally that made sense both to them and to the Medicare Advantage members. We did see significant improvement across 2 measures from Wave 1 to Wave 3 that were performing poorly, which were the getting needed care without delays and getting appointments and care quickly. So we are anticipating to see a positive impact on our CAHPS, our official CAHPS survey this year, which we'll get those results back in June or July. So we're super excited. Next slide just shows the continuation of the action plan that we implemented. All right, next slide.
Great, thank you, Christina. Our next guest, David Larsen, has been the Director of Quality Improvement for Select Health in Salt Lake City, Utah for the past 26 years and has worked for Intermountain Healthcare for 33 years. Select Health is a mixed model HMO with commercial, Medicaid, Medicare Advantage, and CHIP members in Utah and Idaho. Intermountain Healthcare is an integrated healthcare delivery system with 23 hospitals and over 1,500 employed physicians. As the Director of Quality Improvement, David has responsibilities for oversight of the Medicare Advantage STARS program, for which Select Health received a 4.5-star rating in 2015 and 3.5-star rating in 2016. Also maintaining NCQA accreditation, Select Health is currently accredited with a commendable rating, as well as HEDIS performance measurement, public reporting, and disease management. David was a past co-chair of America's Health Insurance Plan Subcommittee on Accreditation and Industry Standards. Thank you, David, also for joining us today, and I will now hand it over to you.
Thank you. Happy to be here. I hope that our experience in using surveys provided by SPH is meaningful and you can learn something from the presentation today. Next slide, please. Just to further delineate from what Alyssa's introduction, we have 850,000 members. 40,000 of those are on the Medicare plan, 100,000 on Medicaid. We do 8 different CAHPS surveys. You can see we do two commercial surveys, one in Utah, one in Idaho. We do 3 QHP surveys, 2 in Utah, 1 in Idaho, 1 Medicare survey that covers both Utah and Idaho, a Medicaid and a CHIP survey in Utah. So we have lots of different populations to focus on. Next slide. So one of the things we did early on was we experimented with doing serial surveys, and we also experimented with drill down, and we decided what we really liked was the drill down survey, because what we really needed to know is what do we need to improve on, what do we need to work on, what's actionable, because we knew our scores were not where we wanted them to be, but we could guess at what we thought would be the reasons why people were not happy, but oftentimes we weren't exactly right, and we found ourselves trying to improve in areas that we were focusing on the wrong things. So we decided to move forward with drill down surveys. We've been using drill down surveys for several years now. One of the things we decided to do was, if we were going to do drill down surveys, there was no real need for us to do custom questions during the official CAHPS survey, and thereby we could shorten the official CAHPS survey, get a better response rate for those surveys, because we weren't extending the length of the survey. We reserved the custom questions to the drill down surveys and conducted the survey August-September time frame, which is outside the moratorium window period for surveys, allowed us to get the surveys done and still have time to implement action plans to try to improve our rates. We focused on, you could ask drill down questions on almost every CAHPS survey, and I think we tended to do that at the first, but then the survey was really long. So we decided to only ask drill-down questions on problem areas that we identified through the official CAHPS survey, and areas where we wanted to try to improve and where we wanted to get information about specific questions. We also drilled down on all of the rating questions with open-ended questions as to why the member rated their health plan, drug plan, or overall health care provider or specialist the way they did, so that we can get more drill down on those specific areas. Next slide, please. So when we did the drill down logic, we also wanted to be able to segment the population into subpopulations so we could, again, be more specific about where and how we needed to improve our survey results. So what we did was we increased the sample sizes to allow us to try to get 50 respondents per cell. So, for example, we have 6 regions in Utah, so we wanted to have enough respondents that we could be able to look at the satisfaction across our service area broken down by region. We also wanted to look at the effect of high deductible plans versus a standard deductible to find out what the impact of a high deductible has on member satisfaction. We also wanted to look at integrated Intermountain Medical Group clinics, or our partners, our St. Luke's Health partners in Idaho, their response rates versus affiliated contracted clinics, to know if the problem was isolated with a type of physician practice. And we also drilled down on plan. So within the commercial plan, we looked at, small employer plans, large employer plans, and to be able to determine different product types. So smaller panel products, larger panel products, what type of plan within the commercial population and how their satisfaction rates compared. Next slide, please. So this just starts some examples, and I hope you can see some of this on the slide. It's not critical that you see it, because what we're doing here is we're saying, for these questions, we then, this is an example of the segmentation analysis. So for these various questions that related to problems that we found on our surveys, and this is Medicare specific, we then looked and said, okay, what regions are having the biggest problems with these particular areas? So question 1 has to do with getting routine care, and our region 6 is the lowest rated area. So we would ask ourselves, okay, what's different with region 6, and what can we do in region 6 to try to make a difference? Then there's some questions related to office wait time. We'll get into that a little bit more specifically, so I won't focus on that now. Access to specialists, for example, which region is having problems with access to specialists, and that would be region 5 and 6. And you can see on down the different types of questions that we asked, and we'll get into some of those more specifically. So let's move on to the next slide. And here's an example of the segmentation analysis across PCP groups. So we did this based upon the member's attribution as to who their primary care doctor is, and whether they were part of the St. Luke's, Intermountain, or Utah, Idaho affiliate groups, and we wanted to look and say, what's the difference in satisfaction, and what access to care, all these different questions. How did this rate? And it was interesting, the results, what we found. Some of them were a little bit more of a surprise, in that we had more access to specialist issues from affiliate clinics. Getting routine care, we were a little surprised that the Intermountain Medical Group had more of a problem than the Utah affiliated doctors had a problem. You see there's quite somewhat of a large variance there, from about 96% of Medicare members saying they didn't have a problem getting a routine appointment from a Utah affiliate primary care clinic, down to 87.5% of members who had a primary care physician in our medical group having a problem with routine appointments. Let's move on to the next slide, please. So here's an example of the routine care as soon as you need it? Was it a problem? So when we drill down on this, the problems with getting a routine appointment are twofold, and I've highlighted two of the areas that we came out of the survey and what helped us to understand. So first of all, as you might expect, the largest majority said they couldn't get a timely appointment. The next group of individuals were trying to get routine care from providers who were not on the panel. That was something that we hadn't really thought was such a big issue. So obviously we need to do a better job of educating the members about availability of providers on the panel, and we need to assist them in getting appointments with physicians who are already on the panel and try to alleviate that problem. Next slide, please. Another question we drilled down on was we thought that the members had a problem with waiting time, and that was contributing to their access issues. But what we pleasantly surprised, and you can see from this, is that 95% of members were able to see their doctor within 30 minutes of their arrival. That was sort of amazing to us. Very low, or very, good access across in terms of wait time. So that really wasn't something we needed to focus on. We could have spent a lot of time working with offices to try to minimize the wait time, but we found that that really wasn't a problem. We could move on to other issues. Next slide, please. So one of the other things we wanted to focus about was the quality of health care they received. This is one of the rating questions. We wanted to know how they define quality of care. And so we asked them what were their most important factors relating to the quality of care. And some of these you may be able to anticipate. So one of the biggest areas was the professionalism of the office staff. Another one was a relationship with their doctor, communication from their doctor about their test results, which was interesting, a high rating. Something we've tried to focus on is test result communication. And then the ability to see the doctor that they want to see, access and choice. So, those are the kinds of things, not a lot of real eye-opening things there, with the exception of communication from their doctor about test results. Patients really want to know in a timely manner what the results of their tests are, and we really hadn't clued in on that without looking at these survey results. Next question, or next slide, please, thanks. One of the other things we wanted to find out was from our Medicare Advantage members, what type of specialist are they having trouble getting an appointment with? We know we were somewhat lower than we wanted to be on specialist access. So by asking this question and including various specialists, we found that orthopedists and dermatologists were the biggest issues. We anticipated that rheumatology would be higher, but we hypothesized, because we had some rheumatologists who left our network and since been replaced, but at the time of this survey they had left, we just hypothesized that the survey sample didn't include enough people who needed to see rheumatology for it to have to pop up on the survey as a higher area of focus. And so we asked again another drill down question. Sorry, my screen just went to sleep. Let me just. So the next question drills down again on seeing a specialist. What was the problem with seeing a specialist? And again, we came up with the same issue as we had with primary care, which is they couldn't schedule an appointment, but more importantly, they were trying to see specialists who are not part of the insurance plan. So again, it tees up the idea of we need to do a better job of educating what specialists are on the plan and assisting our members in getting appointments to specialists that are on the plan. Next slide, please. So one of the questions related to STARS is a question related to were you able to get care and services that you felt were necessary? So we wanted to find out what kind of services were they not getting that they felt were necessary. And the biggest issue was prescription medicines. We sort of thought that was the case. And then we asked an additional questions, what kind of problems did you have with your health plan when trying to get care, tests, or treatment? And first of all was, I couldn't get approval from my plan, so they were trying to get coverage for something that wasn't covered. It was not a covered benefit, and then as well, I could not afford the cost of care. So there are multiple issues there identified, and they're somewhat intuitive. For the most part, they were looking for access to care for providers outside the network, services that were not covered, or they simply couldn't afford the care, which at 36% was a little eye-opening in that there's quite a few seniors out there that are avoiding care because they can't afford the care. Next slide, please. Now we wanted to focus in on prescription medications. Our overall rating of the drug plan is not wonderful in terms of the rating. We've struggled to try to find out ways to try to improve that. The rating across all Medicare Advantage plans in Utah is not very high. All plans sort of suffer with this, so we're trying to decide what is it that we're really going to do to try to improve the drug plan, because every year we think we've done something to improve the rating of the drug plan, and the rating doesn't improve. So we're really trying to drill down and find out what's happening with the rating of the drug plan. So we said, have you had a problem when filling a prescription at the local pharmacy? Majority of people said no, around 90%. That doesn't seem to be a major issue. But we did ask them if they had problems in filling a prescription, so that's the 10.9%. We said, what were those problems? And the biggest issue is the drug prescribed by their doctor was not covered by the plan, or I could not afford the cost of the medication. So again, two specific issues for us to work on and try to improve formulary prescribing from our panel providers, as well as ways that we could try to work with members to find drugs that are more cost friendly for them in terms of filling those drugs. Next slide, please. So then we wanted to talk about why members have not filled or not filled a prescription with our mail order service. So first of all, why we asked them an earlier question, if they have filled the prescription with a mail order. The majority of members indicated that they had not used mail order. So we wanted to find out why they didn't use mail order, and this kind of another mixed response was, first of all, they didn't know that we offered a mail order benefit. So obviously something we need to do a better job of educating our seniors that mail order is available and what are the benefits of using mail order. And then the second one was they knew how to use, they had a mail order, but they didn't know how to use it. So again, our fault for not being more clear on how to use the mail order benefit. The majority of people who hadn't used it really liked the local relationship with their pharmacist, and we sort of anticipated that, and we don't want to interrupt that, so if that's where they like to go, that's fine. And for some reason, people felt that going to the local pharmacy was more convenient than receiving the prescription in their mailbox, which is a little, out there as a misnomer, but, seniors value going to the pharmacy. When they go to the pharmacy, they usually go there for other things besides their medications. So, they feel it's more convenient. Next slide, please. And so then we asked them this question about getting medical care. Was there ever time? So what we're trying to drill down on here is the coordination of care question, which, again, is a STAR measure, but it's made up of multiple different measures. and you really don't know which part of that you need to focus on and what's more meaningful to the members. So the majority of the members said that the issue they had was follow up with their doctor's office to get test results because the doctors had not given them the test results. And we felt that was something we could really get our hands around. So one of the things we did was we also conduct ongoing over the year CAHPS surveys with our physicians' offices. And one of the questions we have on that survey is about each clinic, how the members have responded to this particular question. So from that, we're able to determine which offices have problems with communicating lab results to their members or their patients. And then we've communicated that to the office, and then we've tried to drill down with those offices and say, how can you improve? Here are some best practice examples of how other clinics are accomplishing this that's not resource intensive and receiving great results. So that was eye-opening to us and allowed us to further drill down and get some specific actionable items to work on. Next slide, please. So we also, as mentioned earlier, we have open-ended questions about why individuals responded in the way they did in rating the plans, the drug plan, the health plan, their health care. And then we also asked them, what suggestions do you have for how they could improve in order to get more information and drill down? And essentially there's a lot of comments, and we read through those comments and try to categorize them and see what it is that people want from their plan. Next slide, please. So based upon all this drill down, what did we do? What kind of actions did we take to try to improve satisfaction of our members? One of the things we learned through the questions related to the drug plan is that the biggest issue with the drug plan is not that the drugs aren't covered or the copays aren't exactly what the member wants. What they really were reacting to were surprises. It's not appropriate for them to show up at the pharmacy and find out that they now have a drug deductible that they didn't know about from the prior year, and now they have to pay out of pocket for the first few prescriptions to meet their deductible. That's something that shouldn't happen. They shouldn't go to the pharmacy and find out that we've changed this medication's copay, and it's now a higher copay than where it was last time. So we've really focused in on developing simple to understand member education material about the drug plan that goes beyond the required CMS education material in order to have no surprises. We've changed the style on how we communicate with our pharmacy members on the phone. We ask them questions about, when they call, we ask them questions, would you like to talk to a pharmacist about the drugs you're taking and see if we can save you money? We asked them if they were interested in finding drugs that have lower copays. We're really trying to help them be more satisfied being full service. We've focused on, as I mentioned, doing CAHPS surveys and trying to identify clinics and their overall satisfaction rate with their patients and how that may then attribute to the satisfaction of our plan. We've focused on claims turnaround time. We're implementing a member communication portal, which allows members to go in and specify how they want to be communicated with in terms of they don't want to receive mailings. They'd rather receive emails or phone calls or vice versa. We're trying to be more customer-friendly and communicate with them. Some members get very upset with the amount of mailing that comes into their mailbox. If that's the case, then we need to stop sending them mailings. We need to focus on communicating with them via email. And then lastly, we focused on access enhancements. We've implemented a telehealth program to be able to access urgent care over the phone through a Skype kind of activity. We've implemented a nurse line for after-hours triage. Actually, it's 24-hour triage. recruitment of specialists and behavioral health providers in areas where we were deficient in trying to improve access. So doing the drill down survey has greatly enhanced our ability to focus on specific areas that we can be action-oriented to improve our satisfaction rates. And so far, with using SPH, another little plug here for SPH, I'm able to go on through their portal and look at the survey results coming in on our Medicare survey. Right now, we're at about 30% response rate, and I can see how the survey results are coming in and how they compare to the star ratings. And I'm happy to say for several of these measures, our scores are 3 to 4% improved over where they were last year. And so we're very happy with our partnership with SPH. Thank you.
Thank you, David. Before I introduce our next speaker, I just want to remind everyone, if you do have any questions that are top of mind as we move into this next section, please, you can go ahead and enter the questions into the question section of the webinar, and we will address those at the end. So now I'm going to introduce our next speaker, Esther Turner. Esther has been with SPH Analytics for 6 years with a focus on our health plan products and survey solutions. She monitors requirements and updates from NCQA and CMS. Esther's graduate work at Emory University included public policy in both qualitative and quantitative analysis. So I will now hand it over to Esther to present some information on our best practices.
Thank you, Alyssa, and good afternoon, everyone. We're going to start and talk about a little bit more about the drill down and simulation surveys, some best practices and things to consider when you're fielding these surveys. The simulation survey or drill down survey really can be a vehicle for gathering more information, feedback, and really data to drive quality improvement, as we've heard from our speakers previously. A simulation, kind of the difference between the two, a simulation is a fielding of the regulatory version of the survey in the off-season, whereas a drill-down survey covers many of the same topic areas, but probes for more information. So in this section, we'll share some best practices and things to consider when deciding to conduct the survey. And here, I'm going to focus on the Medicare CAHPS survey specifically, but simulations and drill-downs can be fielded for other lines of business as well. All right, planners want to carefully consider their objectives for conducting the survey. For instance, what specific survey measures or star ratings are you looking to improve? Are you seeking to get more information beyond your regulatory survey results to better identify strengths, weaknesses, and therefore areas needing improvement? Or are you looking to simulate the regulatory survey for specific segments of your provider network or member population? You'll also want to think about whether there are specific areas of concern in plan services or delivery of care. Typically, this might include access to care or areas in provider communications, both of which are key drivers of member satisfaction with either their plan or their health care that they receive. You also want to think about if there are other issues or problems that you believe are impacting certain areas. Again, where do you want to receive feedback for this kind of about this information? And then this will help you determine whether a simulation or a drill down survey is most appropriate for your objectives. In terms of methodology, SPHA recommends a similar but abbreviated protocol as the regulatory survey. So we recommend a one-way mail with a phone follow-up. This allows for a shorter time frame than the regulatory survey, but still allows for a mixed-mode data collection. Something to remember when planning for these projects is that CMS does not want plans surveying members during or 4 weeks before and after the regulatory survey administration. This is important to bear in mind when you're thinking about your project planning. Okay, another thing to keep in mind is the size of your membership. We heard some of our speakers talk about this too. You'll want to be mindful of survey burden. And make sure that you have enough members to ensure that you're not surveying members multiple times. So when we think about this, you want to be careful to, dedupe against any of the regulatory surveys or any other surveys that are being fielded at the same time. Your survey objectives will determine the sampling strategy you'll use. So we recommend if you're conducting just a random sample of the member population, a sample size of at least 2,000. An important consideration is whether you want to pull a random sample of members or if you're interested in reviewing results segmented by something like provider group or other market information. Stratified sampling strategy like this is subject to how you want to see the reporting, the size of your practices or the number of types of providers, or different aspects of patient and plan volume. And this is something we would work with you to develop a sampling strategy that's going to align with your objectives for these types of surveys. Okay, let's turn now and look at some of the revisions to the MAPD CAHPS survey. So our Medicare CAHPS drill down survey has been designed to reflect the drill down, to reflect the regulatory survey. And since the regulatory survey has had significant changes made to it this year, we're going to take a minute and review the main updates to the regulatory version, and then we'll talk about the updates that were made to the drill down survey to reflect these updates. All right, so as you know, there were some big changes to the MAPD CAHPS survey for this year. One of the biggest changes was really a reduction in the overall length of the survey. So the longest version, the MAPD version, went from 95 to 68 questions. So the revisions that CMS did really were to shorten it and to reflect the changes to the version 5.0 of the commercial and Medicaid CAHPS health plan survey. So as you can see here, we have a total of 33 questions that were deleted from the survey. This includes questions related to themes about calling after hours, about whether or not providers use a computer or mobile device during the appointment. They also removed questions about reminder calls and about repeat visits for the same condition. They also removed two kind of domain and composite areas. So they removed the section about your Medicare rights, talking about complaints and appeals. And CMS also removed the questions in the getting information about your drug plan composite. So they took away many questions. They did add a few questions to the survey tool. You can see that they added 60 questions about topics concerning extra benefits, co-pays, and then some activities of daily living. Questions addressing things like issues with walking or climbing stairs, dressing, bathing, doing errands, and then use of the internet. In addition to those changes, we also saw some modifications in some of the survey items themselves that stayed on the tool. So 9 survey questions were modified to really get some improvement in the clarity of the questions. For example, whereas the question read about non-urgent care, the language was changed to define non-urgent care as a checkup or routine care. So as a result of those changes that were made to the regulatory version of the survey, we have revisited our Medicare CAHPS drill down survey content to more closely align with those changes. So some of the changes that we made to our drill down survey include taking out items related to that getting information about the prescription drug plan, since that was removed from the regulatory survey. We've deleted questions regarding the visit notes. We've mimicked the language and some of the changes that were made to some of those key questions about urgent care, getting care and tests and treatment. We did add a question about the use of the internet to probe some additional information about that aspect of care. We also added a question about the pneumonia vaccine as well. So we looked at some of our research. We noticed that 30% or less of those in a random sample have actually called customer service. As a result, the valid ends for those on those questions can be too low to analyze or really make good assumptions about. Therefore, we removed this question from the survey, and we recommend that plans conduct a targeted customer service call center satisfaction survey instead to probe on this area. We also made several enhancements to existing survey questions to improve information and insights from those questions. So trying to get some better probes about why members are responding certain ways to these important questions. So things like, where do they go for care? Using the mail order program, reasons for delays in getting care, and then questions about the experience with care coordination. So the updated survey template has 56 questions. 12 of those are have a series of response options to choose from, and a verbatim comments question, or kind of like an other, please specify, to get some additional information. We have 4 open-ended questions that ask the respondent to explain or define why or what happened. So shown here are the composite or domain areas covered by the drill-down survey, and all are really reflective of the composite areas of the standard Medicare CAHPS survey. The goal of the drill-down survey is to support the plan's improvement effort by probing multiple composite and individual measures impacting the CAHPS survey scoring and reporting. As you know, Medicare CAHPS scores are used by CMS for both public reporting and the star rating program. They're also used by NCQA for health plan accreditation. So this slide is showing the alignment of key reporting measures that are probed on in the drill-down survey, along with those used by CMS or NCQA for their program. Plans feeling the pressure to remain competitive with public reporting may wish to conduct a drill-down survey to get some better insights on what's impacting their members and where to focus those areas of improvement. When we talk about next steps, it's usually discussions with your survey advisor or sales executive, where you review your CAHPS data and identify areas for further insight and drill down. You want to be careful here to define your goals and objectives and decide which survey and which protocol and sampling methodology makes the most sense to achieve your goals. Then it'll be a matter of conducting the survey, analyzing the results, and then collaborating with your quality improvement teams to initiate change. Terry, I will turn it back over to you for questions.
Thank you, Esther. We will now open the presentation up to questions. I have one lined up already. Let me read this. It says, please tell me the recommended times for conducting the survey.
Okay. Yeah, that is a good question. So the official CMS kind of blackout period is 4 weeks before fielding of the regulatory survey, and then during the fielding, and then 4 weeks after. So that roughly, that timeline is anywhere from what we have here, February 1st to June, the end of June. So really you're looking at kind of a fall administration for these off-season projects.
Hold on one moment, I see one coming in. Bear with me one moment while this, the typing completes. It says, is it recommended for Medicaid and Medicare?
So yes, so a drill-down survey is recommended for all lines of business. We have plans to conduct a drill-down survey or a simulation survey for actually Medicaid, commercial, Medicare, as well as QHP for the exchange population.
Another one coming in here. Do the drill-down questions need to be NCQA-approved questions, or do plans have flexibility with wording or context?
If it's off-season, there's more flexibility there. Yes. Since these are not submitted, there's flexibility in terms of what questions the plans can ask.
Okay, next question. For plans participating in off-season surveys for the first time, are there any recommendations or general guidance for them, mainly around how to tackle issues identified?
So typically when we have a plan approach us for a drill down survey or a simulation survey, we'll first want to take a look at your results from a CAHPS survey of your previous administration and go through those results and really talk through it with you so that we can identify those key areas that maybe you're a little bit concerned about or saw a fluctuation in the scores and are just not sure what's going on. Those would be the first areas that we would go through with you to make sure that we include those in the drill down survey.
Great, thank you. Next question. What was the buy-in from provider office after comparison between CAHPS and insurance CAHPS survey in terms of enough sample size for practice level?
Yeah. So, I think that question might hand over to David.
Yeah, good question. We want to get high number of patients satisfied on the CAHPS. So we've really invested in CAHPS. Originally, we were trying to get at least 30 responses per clinic, and now we've really upped that so that we're essentially surveying continuously on the provider office. We have some limits so that you're only surveyed once per year per provider, so that we don't call that person multiple times for the same physician. But we're getting hundreds of surveys per clinic, which allows us to be very specific down even to the individual physician level to be able to compare their rates and how their rates impact the clinic rate and how then the clinic rate affects our rate.
Thank you, David. Next question. Can plans get the data back from a drill down or simulation survey, unlike Medicare CAHPS regulatory data, for example?
Yes. Yeah, so one of the benefits of doing the off-season simulation or drill down is that we aren't, because it's not submitted to CMS, there's a little bit more flexibility in how we can get you that data and how we can segment that information.
Good. Next question. Can you still do a drill down proxy survey during regulatory CAHPS if you scrub the list and don't send it to the same member?
The CMS highly discourages fielding surveys to members during the regulatory season. We recommend that any drill down information is collected off season from the regulatory.
Okay, well that's all the questions I have lined up here. I'd like to thank our speakers today, Christina Lateral, David Larsen, Esther Turner, and Alyssa Simpson, for this enlightening presentation on improving CAHPS with drill down and simulation surveys. We also invite you to register for future SPH Analytics webinars by visiting our website at spHanalytics.com/webinars. On behalf of SPH Analytics, we would like to thank all of you for joining us today. We hope you have a great day and will join us on a future webinar. Thank you again.